at the University of Oklahoma Health Science Center in Oklahoma-City, Oklahoma. And Oklahoma is a small state right above Texas. I'm also the section chief of rheumatology and the associate dean for research for the College of Medicine. So today we're going to be talking about a highly prevalent condition in the United States, and I predict will be highly prevalent there in Ukraine, called fibromyalgia. Next slide. So fibromyalgia is one of several soft tissue pain syndromes, and it's characterized by widespread musculoskeletal pain with a decreased pain threshold and tolerance. And these patients have extreme hypersensitivity to external stimuli. Even their clothing can hurt. They may have what are called tinder points, which are specific areas that have tinder knots. The patients can describe them as knots or swellings. It's often associated with significant fatigue and non-restorative sleep. So they may sleep, but they don't ever wake up feeling refreshed. Most of the patients have significant brain fog, and then a large percentage of them also have a lot of somatic complaints, which we'll talk about later. When you do the physical exam, there's no objective inflammation, and when you look at their laboratory findings, they're typically completely normal. There's no abnormalities in labs. Next slide. So what do we know about fibromyalgia pathogenesis? Well, we know it's not a muscle disease. If you look at the muscles, there's nothing wrong with them histologically. If you look at the joints, there's no joint abnormalities. There's no abnormalities in the bones, and there's no organ dysfunction. Next slide. So what we do know is that there's a sensory processing abnormality. So the peripheral pain sensory input is significantly amplified, and the patients also have a decrease in the inhibitory pain signals. So you have pain signals that go up to the brain, and then there's usually some level of tolerance, and there's some inhibitory pain signals, and they're not developing those inhibitory pain signals. And so they end up developing central sensitization of pain processing. So this is really a pain sensation and processing problem. And it's almost always associated with this insomnia, non-restorative sleep. They either can't get to sleep or they fall asleep and then have frequent awakenings, frequent arousings, and then they just wake up feeling exhausted. Most of the patients have some psychosocial or behavior factors that have contributed or have, led to the development of fibromyalgia. And that can be things like divorces, severe financial problems. We'll talk about how war and things like that can make a difference. It can be sexual trauma. Sometimes it's true psychological conditions like severe anxiety disorders or depression. Next slide. So this is one example of the pain response abnormalities seen in fibromyalgia. And so they basically use the equivalent of a blood pressure cuff, and the light blue are people without fibromyalgia, and the dark blue are people with fibromyalgia, and the pain scale is on the left-hand side. And you can see that at every area, the deltoid, the forearm, the calf, and the thigh, patients with fibromyalgia had a significantly higher pain sensation than the patients without fibromyalgia. So this is part of that pain, abnormal pain sensation. Next slide. So this is one example of kind of a comprehensive one-page, how could you screen for fibromyalgia? And so on the left-hand panel, you'll see the front and back side of a schematic of a person. And they're asking for, have you had pain in any of these areas? And you can tell just right away it's widespread. So it's not just the back, it's not just the arms or the legs, it's kind of all over, and can even include the jaw, the neck, the breast, the abdomen, and then, lots of areas of the arms, legs, and back. And then associated with that are the symptoms of fatigue. So in the right-hand side, fatigue, trouble thinking or remembering, that's the brain fog, or waking up unrefreshed. And you can see that the patients can score themselves what they consider no problem all the way up to a severe problem for each of those. And then other associated symptoms, are you having pain or cramps in the lower abdomen, depression or headache, yes or no? And then finally, additional criteria, have you had symptoms 2 and 3 and widespread pain for at least 3 months, and yes or no? And do you have another condition that would explain these? So this is a pretty good screen for fibromyalgia, and can let you, as the provider, know how impaired patients may be from this. So next slide. So other syndromes to think about when you're thinking about fibromyalgia, this is the elephant. And so you can see on the left-hand side that blindfolded doctors may be saying, oh, the tusks are spears, the ears are a fan, the big side of the elephant is a wall. So everybody's examining a very focused part of the big elephant, and they're missing that it's an elephant. And then on the right-hand side, you can see all of the different components. So you can have chronic back pain, irritable bowel syndrome, functional weakness, TMJ dysfunction, chronic fatigue, all of these, and even interstitial cystitis, atypical chest pain, and various gynecological painful syndromes can be associated with fibromyalgia. Next slide. So additional things that can happen in fibromyalgia are characterized by this schematic here. And I'll just point out the ones on the far right-hand side, the autonomic disturbances. So along with the brain fog, patients will typically have kind of non-specific symptoms of blurred vision, the light hurts my eyes, dry eyes. They may feel like they're wobbly when they're walking. They may have dry mouth, or, so dry eyes and dry mouth we call sicca symptoms. And sometimes patients can feel like they're cold all the time, or actually have Raynaud's phenomenon, where they either due to stress or cold, most often, their fingers, sometimes their toes also, will turn white and blue, and then upon rewarming or calming down, the fingers will turn bright red and warm. And this condition can be very painful. Other patients will have orthostatic hypotension. And then the regional pain syndromes below go along with the elephant we just saw, where you can have migraine and headaches, dyspepsia, irritable bowel, dysmenorrhea, vulvodynia, and dysuria. So these are the other things. And at least in our practice, when we see patients, it's very common that they'll have a variety of 1 or 2 of these symptoms from every one of these boxes, and that will go along with their fibromyalgia. Next slide. So major depression also goes along with musculoskeletal pain, including fibromyalgia. So if we look at patients with chronic soft tissue pain like fibromyalgia, close to 50% will have significant depression associated with it. whereas rheumatoid arthritis patients, about 40%, and patients with osteoarthritis, another chronic painful condition, about 33%. So we know that depression is associated with chronic pain, and that depression increases the pain levels in patients with arthritis. We also know that depression is more prevalent when patients have lost the ability to do their valued activities. So they may be socially isolated. They may not be able to perform what their hobbies were because they have so much pain associated with activity or after the activity. Next slide. So somatoform pain syndromes can also be seen. And so one of the things to know, and I think has caused some controversy in the field, is fibromyalgia actually just a somatoform pain disorder, or is it's a real disease? And at least the American College of Rheumatology and our training here in the United States now considers fibromyalgia a chronic pain condition and not just a somatoform pain disorder. But remember that even with somatoform pain disorders, patients are not intentionally causing their symptoms. You know, these patients do have real symptoms, but usually they're tied to significant anxiety or significant depression, and not necessarily related to this abnormal pain sensitization that we see in fibromyalgia. Next slide. So if a patient has fibromyalgia, you know, usually it's, you know, they're complaining that everything hurts. It's not just, you know, they'll go, oh no, it's not the joints, it's the in between, it's the skin and the muscles here that hurt, or the here. And so that's almost always a clue that it's going to be fibromyalgia. 20 to 30% of the patients will have paresthesias. So they'll say, oh, they sometimes get numbness and tingling in their hands or feet, or they'll get some shooting pain that starts at the fingers and goes up instead of down, and you know, instead of like neurological pain that would start at the neck and go down. So they tend to have a lot of paresthesias that don't fit a dermatome or don't fit into a neurological pattern. This marked fatigue and functional impairment, they may tell you, oh, I had a good day, so I went and did some shopping, or I went out and did something, played with the grandchildren or played with their own children, and then I was in bed for 3 days because I couldn't do anything afterwards. That's pretty common for fibromyalgia. And again, there's no specific signs of inflammation. That the exam is usually normal, except for it hurts everywhere you touch them. So next slide. So things that you have to think about, and whenever I see a patient referred for fibromyalgia, I'm going through this list in my head, and I'm asking questions, and then we'll do blood tests to rule these things out. So, you know, hepatitis C can be highly prevalent in the United States in certain populations. And we know that chronic active hepatitis C can be associated with what I call it hurts all over symptoms. And so it can be associated with fibromyalgia. If you find it, you try to treat the hepatitis C. Celiac disease is very common. Patients here can have intermittent diarrhea or constipation. There's probably more patients that have celiac disease than realize have celiac disease. So if they've had any complaints of bowels that hurt, that are abnormal, or they have some painful joints along with the fibromyalgia symptoms, I'll check a celiac panel, a transglutaminase and an anti-gliadin antibody. We want to make sure their thyroid is functioning well. Hypothyroidism can cause this. Hypercalcemia, moans, you know, bones, moans, and psychic overtones can look very much like fibromyalgia. So you want to make sure they're not hypercalcemic. Sleep apnea may be causing their non-restorative sleep and could be contributing to fibromyalgia. So if you find it and can treat it, you may be able to improve their fibromyalgia or make it go away. Some medications can be associated with fibromyalgia, medicines like prednisone, for instance, that would cause patients to have more awakeness and have poor sleep. Chronic viral infections can do this, EBV, CMV, but most of the typical viral infections that they could temporarily cause fibromyalgia for up to 6 weeks, but then the symptoms should go away. And then cervical stenosis can mimic fibromyalgia in kind of everything hurts. So if they're having true neck pain, it's worth getting x-rays of their neck. Polymyalgia rheumatica. So this is a condition that will be significantly associated with muscle pain and can sometimes be confused for fibromyalgia. Patients don't feel good. They may have non-restorative sleep because they're having so much pain in their muscles. But remember, this is proximal muscle pain, but without weakness. And so if they're over 50 and you think there could be PMR, it's worth checking inflammatory markers. Widespread osteoarthritis can sometimes mimic fibromyalgia. RA, lupus, myositis, all and osteoarthritis can all be associated with secondary fibromyalgia from the condition, from their autoimmune or osteoarthritis condition. Malignancy can cause patients to have secondary fibromyalgia and Lyme disease here in the United States. I'm not sure if you have Lyme disease there, but and then depression, I already mentioned, can be associated with significant fibromyalgia. Next slide. So in the workup, we would send labs, including the complete blood count, the complete metabolic panel, looking for liver and renal dysfunction, the TSH for thyroid, a SED rate or a C-reactive protein, the calcium and vitamin D. Low vitamin D is very prevalent here in the United States. And, when you have vitamin D levels less than 15, I'm not sure what your cutoffs are, you can have significant muscle and fatigue, muscle pain, fatigue overall, and it can sometimes be contributing to fibromyalgia. Check the hepatitis studies to make sure they don't have chronic active hep B or C, and the celiac antibodies. Unless patients are having significant symptoms of arthritis that is associated with morning stiffness, that's associated with swelling of the joints and is typically symmetrical, I do not get rheumatoid factor or anti-cyclic citrullonated peptide antibodies, CCP antibodies. I do not typically get an ANA unless the patient is also having significant problems with photosensitive rash or a malar rash, or having alopecia, sores in their mouth, and some inflammatory arthritis, or unless the urinalysis or other things are abnormal. So usually there's not many of our autoimmune diseases that completely mimic fibromyalgia, and there's no reason to just send an ANA if you don't think that there's a contributing underlying autoimmune disease, because it's going to come back positive, and then you're going to be like, what do I do with that ANA? And we certainly don't want to put patients with fibromyalgia on immunosuppressive therapies unless they have an autoimmune disease. Next slide. So fibromyalgia, what do we know about it? So interesting enough, it's 8 times higher in first-degree relatives. So there's a strong familial component. Probably part of that is genetic, and part of it could be the social aspects of of the environment that you're growing up in. We do know that the triggers include stressful life events like what you guys are going through right now, trauma, injury, significant emotional stressors, chronic illness, viral infections, and unfortunately, deployment to war or living through war is a significant trigger. The modifiable risk factors include obesity and inactivity. So if one of your patients has fibromyalgia and they're significantly obese, it's very hard. They're often very inactive because everything hurts. And so we'll talk in a minute about how you try to get them on a graduated exercise program to help them slowly rebuild some aerobic exercise. Next slide. So prevalence worldwide is 2 to 3%. It's more common in women than men in the general population, 2 to 1 female to male ratio. The age is typically 20 to 55, and the prevalence is 1 to 8% depending on the criteria used. And again, I just spoke about the genes and the environment, maybe 50-50, and the 8 times higher risk in first degree relatives. Next slide. So there's a few investigational hypotheses, none of which are very, very strong at this time, that include that there's abnormalities in the hypothalamic pituitary thyroid axis or growth hormone axis. Others have postulated that it's problems with serotonin metabolism or substance P. And then some groups are looking at functional regional brain flow using SPEC and can see that there's abnormalities there, but you know what's causing those abnormalities or how to change those abnormalities are under investigation. Next slide. So the suicide risks in fibromyalgia are very high. 10 times higher than the general public. Risk factors for suicidal ideation include significant fatigue, dizziness, and subjective weakness. So patients that really feel like they can't leave the house, they can't get out of bed, are at high risk for suicidal ideation. The ones that are at highest risk for suicide attempts tend to be obese and have drug dependence, such as opiates or cocaine or other drug dependence. Inpatient hospitalization is also a risk factor for suicidal ideation and suicidal attempts. And interesting enough, a study which was published recently that showed that fibromyalgia patients that had less contact with their health providers were the ones that were most likely to have suicidal ideation or suicide attempts. And then on average, a fibromyalgia patient with no suicidal ideation or suicidal attempts saw healthcare providers 40 hours annually. So that's a lot of healthcare use. Whereas the ones that had suicidal attempts or suicidal ideation were not utilizing healthcare that often. So it seems to be that if you can see a fibromyalgia, you or the other provider seeing the patient more often, the less likely they are to try to commit suicide. So this is challenging for us because us as healthcare providers find fibromyalgia patients exceedingly challenging to deal with. They often come with a list of 30 complaints. They want them all addressed on their short visit. And you often leave the room feeling exhausted, emotionally exhausted. So you have to kind of pull those feelings back and really address 1 or 2 of the issues you can at each visit and see them more often than you would otherwise. Next slide. Oh, and then of course, veterans or military war personnel are at much higher risk for suicide attempts if they have fibromyalgia. So here's a question. We have a 40-year-old woman diagnosed with fibromyalgia and she quit her job because of pain and fatigue. Which of the following therapies has the least effectiveness? Is it NSAIDs, low-dose tricyclic agents at night like amitriptyline or cyclobenzaprine, instructions to slowly increase aerobic exercise, or gabapentin or pregabalin. So which answer? Y'all let you think about that. Then we'll go on to the next slide. Good, I see some people put A in the chat.
Gabapentin.
Yes.
Ну,
Let's
найменший. It's less.
least effective. Yes. So let's go to the next slide.
NSAIDs.
NSAIDs, right. So NSAIDs, non-steroidal anti-inflammatory drugs, are least effective for fibromyalgia. NSAIDs and prednisone are no better than placebo when they've been tested side to side. Opiates are ineffective. They do not treat this pain. And patients will be on huge amounts of opiates, but it's not treating this pain. So don't start it. Tramadol plus acetaminophen is better than placebo, but here in our practice and most rheumatology practices in the United States, we do not use this combination. We do use amitriptyline, and it can improve symptoms 30 to 50%, a single nighttime dose of amitriptyline. Cyclobenzaprine, which is a muscle relaxant at bedtime, can also improve symptoms, and sometimes patients can tolerate taking a twice or 3 times a day dose if they're having significant trigger points. But in my estimation, most patients end up just taking the evening cyclobenzaprine, and it helps them sleep better, get more restorative sleep. Pregabalin and gabapentin can also be helpful, but again, I don't find these more helpful than 20 to 30%. So if the patient thinks it's going to take all their pain away and that they're going to feel 100% better, you have to, set the expectations that this may help with the sensation of the pain. It won't be as severe, but it's not going to make the pain go away completely. Often the duration of these pharmacological agents is limited, and you have to go up by doses, and then eventually the side effects are too much and the patient can't tolerate the drug anymore. So what is a cure, and what can significantly improve, if not cure, significantly improve fibromyalgia, is aerobic exercise. So I usually recommend, if the patient has access to one, a recumbent bike or an elliptical or swimming, or not necessarily swimming, but just water therapy, getting in the water, moving around, water aerobics. They don't necessarily have to do, total swimming, but anything that gets their heart rate up can be helpful. The problem is that most of the fibromyalgia patients, especially if they've been veterans, been in war, want to go back to their same level of function they were before they developed fibromyalgia. So they'll hit the gym hard or they'll exercise hard, and then they won't exercise again for 6 months because they hurt so much afterwards. So if it's somebody that's sitting and not doing much, they're on the couch, I'll just tell them if they can set their smartwatch or their phone to remind them to get up every hour or 2 hours and just stand in place and march in place for 30 seconds or a minute, several times a day. And then eventually, when they can do that with less and less pain, to go to 2 minutes and then to 5 minutes, and then walk around the block if they can, if it's safe, or things like that. So next slide. So the goals of therapy are really to keep the patient functional in spite of the pain. So like I said, none of these things will actually make all of the pain go away, and the patient should not have the expectation that these things will make all of the pain go away. You're trying to get better restorative sleep. You're trying to treat the coexisting depression and anxiety. You're really emphasizing sleep hygiene, no caffeine after 3 in the afternoon, no lights on in the bedroom, no animals on the bed if possible. And then really trying to get a conditioning exercise program together. You really want to encourage them to have social interactions, and if they can work, to work as much as they can, and not quit doing their activities, because that contributes to more anxiety and depression. Next slide. So again, don't start it. Prednisone, no better than placebo. Opiates do not work. Steroids and narcotics are not an indication for fibromyalgia. If you inherit a patient with what you think is fibromyalgia that are on these things, do your best to slowly wean them off. They're going to be very conditioned to want to take these medications, but try to slowly wean them off and try some of these other agents. Next slide. Maria, is there an, oh,
Yeah.
here we go. Yeah,
Yeah.
okay. So I just talked about the aerobic exercise. So a paper was just published that showed that Tai Chi twice a week was as good or better than aerobic exercise and had sustained effects for 6 months after stopping the Tai Chi cohort. So Tai Chi is something people can do in their own house. They can get a video or a YouTube, they can learn it. Or if you have a program that can teach it, this can work for all age groups. So if they don't have access to something that can allow them to get aerobic exercise, Tai Chi is a really good option. And I was really happy to see this, this paper come out. All right, so also it's good to remember that the patients are frequently going to have flares that are related to their stressors in life, or they got ill and didn't sleep well for a few days because of coughing or whatever. They're going to have a flare, and you're going to have to use maybe change their medications temporarily, but not permanently, or give additional psychological support. Next slide. All right, so these are the medicines that we've talked about already, and you know, trazodone can be helpful for the sleep, but it can cause vivid dreams. And so if a patient has PTSD, you may not want to use this. Studies have shown that the low-dose amitriptyline is actually better for sleep in fibromyalgia than trazodone is, but amitriptyline can cause a lot of dry mouth, and so you can just try one or the other and see what the patient responds to. And then the last medication on here is low-dose naltrexone, 4.5 milligrams a day. So this is came out a few years ago as a option, and so it's tightly regulated here in the healthcare systems that I practice in. So I've probably only gotten to use it maybe 10 times, but I would say 30% of those patients actually did really well with it and were able to come off of a lot of the other medications. So it's worth trying. I don't know if you can get it in Ukraine or not. Next slide. All right, so another thing that I really like to recommend to patients is, I don't know if you have those there, or certainly you can order it here in America off of Amazon, but are things like this Theracane. And so you see the little knots, the little knobs on each of these. The Theracane is designed to be able to get the tender points that happen on, that tend to be in the mid-scapular region there. You can see, and along the scapular border, patients can get these very, very tight knots that are very tender to palpation. It's hard for them to let other people massage them because they hurt so much at the beginning. But if they can use this Theracane, then they can start with the pressure they can tolerate. And then as they work that knot out, they can get deeper and deeper massage themselves. So it can be quite effective. Sometimes if you're seeing the patient in the clinic, you can either do dry needling, where you just take a sterile needle and you poke it right into that tender area and kind of move it around a little bit, or inject with lidocaine, and that can give some temporary relief for a day or two, but the knots always come back. So, so I don't typically do this unless somebody has a really painful one that is limiting what they can do, you know, at work or socially. But some patients do really well with acupuncture, chiropractic manipulation, massage, You know, and like I said, if they can tolerate deep tissue massage, then massage once a week or once every 2 weeks, if they can afford it, can be very helpful. Next slide. All right, so this is an active management pain program that are starting to be looked at here in our veteran hospitals, where it's a comprehensive program that will use cognitive behavioral therapy and movement, like Tai Chi or other things, and then some training to the patient to help them rethink pain, especially in the context of fibromyalgia. They set goals, they have stretching, because stretching can actually be helpful for fibromyalgia as well, how to change the unhelpful thoughts that they're having and what that impact is on their body. And then other things that they can use themselves so that they can take some control over their own condition, like the transformation zone, Theracane, learning specific movements. And then eventually working on balance, endurance, and strength, working on sleep, and then meeting in small groups so that patients can meet with other people like themselves. And they often help each other by talking about what helps them or doesn't help them, or just being able to talk to somebody that understands them at the same level that they're at. All right, I think that's it, unless there's one more slide. I think maybe just a thank you slide. All right, so thank you. I'll take questions.
So thank you so much for your lecture. Yes, and if honestly, it's most strange disease for me, diagnosis. Yes, and I was not familiar with this pathology from my university. I mean, my education. Yes. Of course, it's my area of clinical interests, yes. And if so, it was interesting, yes, for me. And I have one question. If I understood, you told about number of male and female. And female we have in 2 times more than male. Why? What is the reason for this? What is
Yeah, so we don't know. It's unclear why females would have it more than males. And you know, a lot of people have postulated that you know, the women, when they that already women have some sleep, if they have children, they're already somewhat sleep deprived. And then if they have other things that happen to them, psychosocial issues and things, that they're just more, they're closer to getting to fibromyalgia at baseline, but it's really not clear. You know, it certainly is not the 9-to-1 ratio we see with our autoimmune diseases like lupus. It's more similar to the 2-to-1 ratio we see of women with rheumatoid arthritis to men. So, but it's not clear why women are more susceptible.
Mhm.
It may be that it's underdiagnosed in men. That's another option, right? Because men, you know, may not seek healthcare for some of these problems.
Thank you. Colleagues, who has questions, please?
So Dr. Tompkins asked, do the symptoms relate to menstrual cycle? And no, this is not really part of PMS per se. And so it doesn't, and it doesn't seem to be tied to menopause either.
Mhm. Maybe questions, or it's so strange topic for you. Please.
Thank you very much, dear Mary, for your perfect lecture and the presentation. We are pediatric specialists, rheumatologists together. And first, our questions about pediatric patients with fibromyalgia. Did you have like these patients in your practice or not? And what are clinical features of fibromyalgia more specific for children? Thank you.
So I'm an adult rheumatologist, so I don't have them in my clinic, but I do know that in our pediatric rheumatology population here, we are seeing increasing amounts of fibromyalgia in children. The features are very similar: widespread pain, fatigue, they don't want to go to school, you know, they say they can't walk around school, they don't want to play. And so the treatments, again, can be more challenging in this age group, but really working on sleep hygiene, working on underlying depression and anxiety or concomitant depression and anxiety, and then really trying to get them into an exercise program, right? Because most of these kids aren't exercising anymore, and we know that that's going to contribute to longer lived fibromyalgia. Yeah, we're starting to see it as primary. It was not uncommon to see it associated with severe lupus or RA, systemic JIA and things like that in our children. But I think, we're just, especially after COVID, we're seeing a lot more childhood depression and anxiety and associated fibromyalgia.
Yeah, thank you very much.
And one more question: what is the primary? Is it pain syndrome or psychology problem?
I think it's a pain syndrome. I mean, I do have quite a big number of fibromyalgia patients that really don't have significant depression or don't have significant anxiety, and so I think a lot of them had something at the beginning, because almost every one of my patients can tell me there was a death in the family, they got divorced, there was some kind of significant event that happened, they had to change jobs, so they couldn't exercise, or they took 2 jobs, right? That something happened that changed their behavior that then set this forward. And so sometimes whatever something happened that changed the behavior gets corrected, but they had fibromyalgia long enough that it's kind of that centralization of pain is already there, and now we have to try to treat the symptoms and get them moving again.
Thank you. Thank you.
May I ask a question?
Please.
Is fibromyalgia is independent disease, or it's only the symptom of many diseases, underlying diseases?
I think it's independent of, so primary fibromyalgia is independent of other diseases, but we know that it can be a component of many chronic illnesses. And so that we call secondary fibromyalgia.
So it may be secondary and primary, yes?
Primary, right.
Right. Thank you.
Thank you. Maybe more questions?
Question, please. Okay, you already told in your presentation that there is a difference between stress and fibromyalgia, but maybe you have some more information how to more in depth to tell about these differences, because now we have a lot of patients like this. It is very interesting for us. Where is the stress line and where is fibromyalgia symptom?
Yeah, so I think right, in your environment right now, everybody has stress, right? So you're seeing lots and lots of people that have stress, but fibromyalgia is happening once they have that non-restorative sleep and the widespread pain. So because lots of people can have stress and maybe achy, but once they get a good night's rest, they feel better the next day. But once it's moved forward into they're not waking up feeling refreshed, and as the day goes on, they get more and more tightness and pain all over. I think that's when they're not coping with the stress well enough, and they've moved over into fibromyalgia. Does that answer the question?
I think so. Thank you.
Okay.
So, thank you, Mary. It was really helpful for us, especially this topic.
Useful for us, yes.
Very spread
Thank you.
yes, in Ukraine. So thank you for your lecture presentation, yes, and for time and support of Ukraine and
Yes, well,
Karazin University.
yeah, we're all praying for you guys, and we hope we can get our United States government to send you guys some more money. So, you know, you guys are in for a long road, and I'm sorry. But yeah, I'd be happy to give other lectures and find other people, you know, if you guys need to continue to do this and like this, this forum. Thank you so much for letting me participate. It was really an honor.
Thank
Bye-bye.
Bye-bye.
Goodbye.
Thank you.
Goodbye, goodbye. Thank you.
So, Dr. Tompkins.
Yes.
Dr. Tompkins, I remember your colleague, sorry, don't remember his name.
Hal
Teacher, yes,
Hal Schofield.
Yeah. And we told with him that first lecture will be acute kidney injury. And second lecture, it will be kidney cystic disease, maybe.
Okay, so that's Ben Cowley.
Yeah, Ben Kelly, yeah.
Right. So I communicated with him via text message this morning and alerted him that because of our time change, it needs to be at 8 o'clock our time next week. And he said that, or he texted back that he can give a lecture at 8 o'clock. And I think that, I'm sorry, not next week, next time, that'll be in 2 weeks.
Yeah.
So, and you want his lecture on cystic kidney disease in 2 weeks? Or do you want the renal failure lecture in 2 weeks?
Yes, and he proposed that the first lecture must be acute kidney injury, acute kidney failure, yes, and second lecture, cystic disease. Yeah.
Okay, so acute kidney injury 2 weeks from now, and then cystic kidney disease 4 weeks from now?
Yeah. And of course, tomorrow I sit and write everything, yes, and send email to you and all of our colleagues with this schedule and with the links on Zoom conferences, okay?
Okay, all right.
And of course, your time, I think, no, I calculate, yes, and of course propose your time according to your change of time. Mm-hmm.
Okay, so 3 o'clock your time is best for you?
It's a good time for us, yes, it's comfortable, but if you want, we can change time, it's no problem.
Okay, and are you changing your time next month?
Next month, yeah.
Okay.
This month,
Oh,
the end of March.
in March?
I think so, but I'm not sure.
What I'm not sure, so I should check is this. I don't
Well, we'll check the data of time changing.
I check everything, yes, according to time and so on, and write and send you message with all of information.
Okay, all right.
Thank you.
That's good.
Thank you.
Okay.
Thank you.
I found the talk to be very interesting about fibromyalgia.
Yes, it's true.
Okay.
It was so interesting. Thank you, Dr. Tompkins.
Okay, all right, thank you. All right, I'm going to go to the office now.
Okay, thank you.
Thank
Goodbye.
you very much.
All right.
Thank you.
Bye.
Thank you very much.
Bye.
Bye-bye, thank you.
Коллеги, спасибо всем. Было достаточно интересно.
Да, кстати, никто не знал, но я не знала эту патологию.
Спасибо большое.
Спасибо.
Спасибо.
До
Так,
новых
когда
встреч.
время меняют, я посмотрю все.
Коли тайм змінюють? Хто знає?
Конце
В
марта.
Америке уже змінили тайм.
Ну, в Америке-то да, но я-то думала, в апреле происходит, оказывается.
Не.
Остання
Марта.
неділя марта.
Остання
Березня,
неділя
остання.
Ну, вот у нас
березня, ну все.
получается либо 30-го, с 30 на 31.
Ага, ну,
Пять
все,
лет.
Суббота на воскресенье
Так,
меняется
30-го на
последнее.
31-го.
Ага, в кінці, добре. Ну, то я прокалькулюю, так? І наступного тижня вас запрошую буде...
Не наступного
нерв-
тижня,
Через
через
два
тиждень.
Через 2 тижні ниркова недостатня.
Ну да, і це буде вже 2 квітня.
Ні, це ще буде березень.
Ні, це ще березень буде.
Це ще
Це
березень.
останній тиждень березня буде.
26.
Так,
Ага,
тоді буде ниркова
так,
недостатність.
28.
А в який день буде? Теж в четвер?
По четвергах, завжди
Ще
четвер.
четверга,
Вирішимо
Наталя Станіславовна.
Часом
Ще
це буде або
четверга.
2, або 3 години, або 4. Там саме за Оклахомою у нас було скільки? 8 годин різниці.
А зараз 7.
Подивлюсь, так, зараз 7. Тому
Мгм.
їм змінили час, і вони нам читали лекції по їхньому часу з 7 до 8, а потім йшли на роботу. А зараз їм трошечки потрібно перестати.
Незручно, тому що вони
Ну,
вже в
бо
робочий
в них
час.
же ж там свій
Вони
розклад.
ще працюють, да.
Вони ще працюють.
Вони
Ми
вже
ще працюємо. А
ми
ще
ще працюємо.
працюють в Америці, так.
Вони ще працюють.
Так.
Добре, щира подяка всім. До
Дякую.
побачення.
До наступної зустрічі.
Дякую,
В
Марія
ефірі.
Сергіївна,
Так,
за ініціативи.
Дякуємо.
Дякуємо. До побачення.
Спасибі велике, до
До
побачення.
побачення. До побачення.